California and Riverside. He's been at the forefront of neuropsychiatry on a national and international basis for much of his career and actively involved with most of the major research trials in psychiatry as an investigator or principal investigator. And he teaches regularly to share his knowledge with colleagues, and fortunately was able to join us here today. So please welcome him as he presents an update on how to recognize and manage patients with pseudobulbar affect that are in your practice and you may not know it. Dr. Alva?
Well, thank you, Greg. Well, what a pleasure it is to be able to join you all right now. And let's go ahead and get started right now. It's always a treat to get together with colleagues from different settings, and particularly speaking about germane issues that we may have actually been missing because of the aspect of conditions sometimes flying under the radar. Pseudobulbar affect happens to be one of those particular topics, and so for me it's going to be really a genuine treat being able to actually get you all acquainted with where we're at the present time. Greg was gracious enough to actually make mention about myself and about the work that I've been involved with, and that's me. And disclosures, I've worked with pretty much every major group and have collaborated with the aspect of the development of pretty much every major medicine within the neuropsychiatric field since Risperidone, and that was back in 1994, so quite a few different things. What we're hoping to do today, and the nice thing is that we've got an opportunity of actually doing some live teaching, but also some remote teaching as well, is to review not just the epidemiology, but also the impact of pseudobulbar affect. We're going to recognize the importance of early recognition, particularly as it applies in the primary care setting. Oftentimes individuals come in and they've got specific symptoms that look a bit bewildering and can oftentimes be confused with other things. And hopefully after this discussion you'll have a clearer grasp of what this entails. We'll talk about diagnostic tools to help with fleshing out pseudobulbar affect, and specifically to take a look at the aspect of objectively doing something about this problem. For far too long we didn't really have anything. We actually have something now that's FDA approved that addresses this particular problem in a very good way. And so we'll talk about therapeutic options to deal with this particular condition, since in the past we would only be looking at the aspect of trying to intervene with different agents, hoping that we might be able to placate the symptomatology associated with it. So I just want to reacquaint you with your little buzzers or little dial pads, because we're going to be doing a little bit of testing initially. What we're hoping to accomplish is that you guys actually pick up some good information. So what we're going to be doing initially is taking a look at some questions. You're going to respond to these as best as you can, and then subsequently we'll see whether in fact we've actually met our learning objectives, and that is to actually heighten awareness. So the first pretest question is this one. In the PRISM registry study, the prevalence of pseudobulbar affect was highest in patients with which of the following conditions? Would it be 1, stroke, 2, dementia, 3, multiple sclerosis, or 4, traumatic brain injury? You'll have 10 seconds to respond to this. Second question. In a survey of patients with pseudobulbar affect, approximately how many reported being housebound by their symptoms? Was it 10%, 20%, 30%, or more than 40%? Again, 10 seconds. Good music selections. Third question. Which of the following agents is or are FDA approved for the treatment of pseudobulbar affect? 1, fluoxetine, 2, citalopram, 3, dextromethorphan, 4, dextromethorphan with quinidine, or 5, all of the above. Next question. It's more of a clinical case vignette. We've got a 63-year-old woman with a history of hypertension. She's also had dyslipidemia and ischemic stroke. She presents complaining of excessive crying. She says the crying started after a stroke about 6 months ago and caused her to stay home most days. On questioning, she denies depressive symptoms, says, "I just don't know why I'm crying." All of the following might be appropriate at this time, with the exception of 1, administering the CNS lability scale; 2, asking the patient if laughing or crying episodes match her mood; 3, initiating empiric therapy with SSRIs to identify and treat potential pseudobulbar affect; or 4, if further workup suggests pseudobulbar affect, consider prescribing dextromethorphan/quinidine. How often do you consider a diagnosis of pseudobulbar affect in patients who report repeated episodes of laughing or crying? 1, never; 2, rarely; 3, sometimes; 4, often; or 5, always.
Your love lifted me higher than I've ever been lifted before. So keep it up.
Wow, another question, right? Putting you guys to task right after lunch. Please rate your confidence in your ability to recognize pseudobulbar affect in your patient population. Are you not at all confident? Are you slightly confident? Are you moderately confident? Are you pretty much confident or really very confident?
Ride around with every single guy in town. Hey, hey, whoa, hey, hey.
All right. Hopefully, we'll see some movement in regards to, again, what we end up seeing in regards to how you guys are actually responding to these particular things. Let's start from the beginning. Definition, pathophysiology associated with pseudobulbar affect. Picture's worth 1,000 words.
Pseudobulbar affect, or PBA, is a medical condition that results in sudden and uncontrollable episodes of laughing, crying, or both. PBA is pronounced pseudobulbar affect. It's a disorder that affects some stroke survivors, as well as people with dementia, traumatic brain injury, Parkinson's disease, MS, or ALS. Sometimes a stroke can damage the areas of the brain that control normal expression of emotion, and a disconnection occurs, triggering episodes of uncontrollable crying and or laughing. While mood is how we feel emotionally inside, the term affect describes how we display our emotions to the outside world. In stroke survivors with PBA, mood and affect are disconnected. Healthcare professionals call this mood incongruent affect. PBA is sometimes called emotional incontinence. Just as a stroke survivor may lose control of his or her bladder, also known as incontinence, this condition refers to the inability to control the display of specific emotions. And just like incontinence, PBA can also be disrupting and frustrating. PBA episodes can be triggered by something that is only slightly sad or funny. For example, a funny commercial about puppy dogs may cause tears. A person with PBA may laugh at something that's sad or cry at something that's funny. PBA episodes can also be exaggerated from a person's true feelings. For example, they may sob uncontrollably at something that is only slightly sad. For people with PBA, the disconnect between internal emotions and external expressions can be frustrating, both for them and their loved ones. Stroke survivors have described feeling as if they're going crazy, or sometimes claim that they didn't know that they were so emotional. PBA episodes can sometimes cause embarrassment, and patients suffering from PBA report spending less time with friends and family. PBA episodes may also interfere with participating in rehabilitation therapy. Understanding this condition can be the first step. Simply talking about PBA with loved ones can help. PBA is sometimes mistaken for depression, but it is different. Someone who has depression feels sad on the inside when they're crying. When someone with PBA suddenly starts crying, it doesn't necessarily mean they're actually sad. It is certainly common to experience depression post-stroke. In fact, a stroke survivor can have both PBA and depression. However, PBA is not depression. It is important to differentiate PBA from depression so that the stroke survivor is treated with an appropriate therapy. A range of studies have found that anywhere from 5 to 52% of stroke survivors have PBA. However, not everyone's experience with PBA will be the same. Episodes of laughing and crying can range in severity from person to person. Sometimes PBA symptoms may lessen over time. These episodes can be so disruptive that they interfere with normal activities or cause people to avoid social situations. For some stroke survivors, treatment may be necessary. If PBA is affecting your life or the life of a loved one, talk to a healthcare professional.
Thank you. So, phenomenal. Because see, that sets a stage for exactly the situation right now that we're going to be speaking about and describing. An involuntary or inappropriate outburst of crying and or laughing, which, again, is generally episodic, is brief, and is frequent, and again, may have specific features that are uncharacteristic. In other words, are incongruent or exaggerated based on the circumstance that the individual happens to be in. And because this is a condition that occurs across a variety of different neuropsychiatric conditions, it's really important to have an understanding of what exactly it entails and what type of a disruption is occurring in the brain. Because, by the way, as you heard right now in this video, this was specifically circumscribed to individuals who had had a stroke. Well, if you've had a stroke, you may also develop problems along the lines of mood, depression. And since one of the core features associated with pseudobulbar affect is crying, we can't always think that because someone's crying, they're actually depressed. That could be a release of the aspect of what's felt internally and what's being expressed outwardly. And that's a very important thing because, in essence, it'll help us have a better grasp of what exactly this entails. Remember the last bullet point in the previous slide? Disparate neurological conditions. Or, again, if we can go back one, I think we advanced. There we go. Thank you. So what you'll note is that dementia, the most common dementia that we encounter in the clinical setting is Alzheimer's disease, although there are many others. There's certainly, again, vascular dementia, mixed dementias, frontotemporal dementias, Lewy body dementias, Parkinson's disease with dementia, and so on. But the important thing is that if you consider Alzheimer's, since it's by far the most common one, you're talking about pathognomonic features such as extracellular neuritic plaques and intracellular neurofibrillary tangles. A stroke survivor is somebody that would have had actually an occlusion of a particular area of the brain based on the aspect of lack of blood flow there. So strokes can obviously affect multiple areas. Most common, obviously, the middle cerebral artery would have specific manifestations. But if you look, two very different conditions, right? Traumatic brain injury is one of those conditions that's garnered a lot of attention recently. It's just as easy as turning on a football game and hearing the polemic associated with the aspect of athletics and then subsequent repercussions associated with head trauma. And head trauma ranges all over the place. When you take a look at the aspect of someone riding a bike, skating, et cetera, and so on, hitting their head, having their bell rung. So again, different areas might be affected. Same thing, multiple sclerosis or amyotrophic lateral sclerosis, Parkinson's disease. We're talking about very different pathologies, but they all have an end point that's common, and that is the possibility of pseudobulbar affect. So what you'll note then is that, again, these sudden, frequent, exaggerated episodes of a poorly regulated emotional connectivity between what's felt inside and what's being expressed outside is literally what this condition entails. And it goes back to the aspect of the circuitry in the brain. And when you take a look at what's happening with the corticobulbar tract, this is a tract that's particularly important along the lines of being able to regulate your emotional tone. And when a disruption occurs across any particular area of this particular circuitry, that will lead towards the difference associated with what we see within somebody that is able to regulate their emotional tone as opposed to the individual that has these sudden, uncontrollable outbursts of emotionality. So where the normal individual would have, again, the aspect of, again, the connectivity across these particular circuits, there might be some disruption occurring with the individual with pseudobulbar affect. And as I stated earlier, again, we're talking about disparate neurological conditions that oftentimes end up manifesting in a similar way. So why is this important? Well, imagine you're out with your family or friends, and all of a sudden, in the middle of dinner, you break out crying for a really little reason, or all of a sudden you're cackling at something that, again, would have actually been somewhat, sad or catastrophic occurring right around you. Everybody's going to look at you like, what's going on? And that, unfortunately, oftentimes evokes a degree of distress so that people oftentimes are unable to keep their social interactions the way that they should, and oftentimes people become homebound. Take a look at the percentages. We're talking about 42% of individuals experiencing that. Even going through the aspect of, again, a breakup of a relationship based on, again, these particular episodes that the other individual might not necessarily want to continue to stomach or be around that individual. And certainly the aspect of maybe a more assisted scenario, particularly when there's more debilitating circumstances that are revolving around that individual. So it's not just the aspect of embarrassment and social isolation, it's a situation of really the dissonance that this particular condition brings. And as a consequence of that, it's important for us to be able to recognize it and do something about it. So how common is this? Is this a really rare condition? Well, let's take a look at some history. What you'll notice is that, I've got some pretty old citations here. Charles Darwin, pretty famous, right? Evolution theory and so on. Well, even he in his writings would actually make mention of this particular condition. Certain brain diseases, which might include hemiplegia, brain wasting, senile decay, have a special tendency to induce weeping. So it's interesting really seeing that context even back then in the 1800s. Oppenheim actually coined this particular term, pseudobulbar affect, and described it as spasmodic bursts of laughter or weeping associated with brain lesions. In the early 20s, we basically see another description based on the aspect of pathological laughing and crying and a syndrome associated with it. And then in the 60s, obviously, and 80s also, specific diagnostic criteria being tossed out there because in essence, this was something that individuals were seeing, but not necessarily knowing what to do about it. So the important question, because when you take a look at the literature, it's all over the place in regards to how common or not common this particular problem could be. So a specific study was done where you've got, again, individuals with different types of conditions that are being out based on a particular scale called the CNS Lability Scale. So the Center for Neurological Studies Lability Scale is particularly useful because it helps along lines of being able to have somebody just fill out a little questionnaire, and based on what they score, that might lead you down the path, maybe I need to explore this a bit further. So individuals in this particular study, if they were scoring 13 points, would obviously be considered as, again, having the potential backdrop for having pseudobulbar affect. And what you'll note is that you see those two big points right there, these two. Amyotrophic lateral sclerosis and multiple sclerosis were two conditions that, by the way, are very different. ALS oftentimes will affect younger individuals, well, actually older individuals, and it will actually have a greater degree of impact, whereas MS might deal with individuals that are a bit younger and not necessarily as impacted. Lou Gehrig's disease, basically, it's sort of a death sentence right now at the present time. And with MS, people tend to live a bit longer. But these two conditions were pivotal along the lines of the study of pseudobulbar affect. In fact, the only FDA-approved medicine at the present time, the pivotal work was done with these two patient populations. And because of the disparate conditions that they are, then helped us figure out, exactly, how well this particular type of treatment modality might help out. But if you'll note the percentage of individuals affected with pseudobulbar affect, it's right around 45–46%. Now, interestingly enough, if you take a look at individuals with traumatic brain injury, that's even higher. 1 out of 2 individuals might have pseudobulbar affect. If you take a look at stroke victims, you're looking at closer to 40%. Parkinson's, at least 1 out of 4, and in Alzheimer's disease, about 1 out of 3 individuals. So when you take a look at this and you specifically target individuals that have been affected with a neurological insult, because by the way, you don't really have pseudobulbar affect unless you've had some type of a neurological injury, right? But that's the important point. There has to be a preset situation that's now created insult in the brain, and then subsequently a disruption of that circuitry occurs. But the important point here was that 1 out of 3 individuals with an underlying neurological problem would be suspect of having pseudobulbar affect. And that, in essence, helps us figure out that we may have actually been missing the boat on many individuals, or not necessarily asking appropriate questions in many of the individuals that come in seeking out our help. So the other important thing with this particular registry study was that when you take a look at what amount of medications people were taking, it turned out that individuals with pseudobulbar affect had a higher propensity to be taking different types of medications. So from antipsychotics to older antidepressants, such as tricyclic antidepressants, or other types of antidepressants, particularly within the SSRI class. But the important thing is that prior to the entry of a particular therapy that is currently approved, we were basically trying to stab in the dark and trying to attain some control over this particular condition. So having defined it and having seen that, in fact, it's not uncommon, particularly in individuals that have been diagnosed with an underlying neurological problem, how do we diagnose this? Well, walk through this particular case with me. So we've got a 54-year-old Hispanic gentleman who presented following a recent stroke with residual left hemiparesis. During the visit, he starts crying. And when asked about his crying, he says he's not sure why he's crying. Denies symptoms of depression. Because obviously it's pretty easy to flesh out depression, right? You've got to have a greater than a 2-week time period feeling depressed and hedonic with at least 5 associated vegetative symptoms that are impacting your function. So that's pretty easy to do. We've got the diagnostic criteria for that. But the interesting thing is that this gentleman basically denies any vegetative symptoms. And then subsequently, he has a brief episode of tearfulness interspersed with laughing. Now, the interesting thing with this particular case is that, it poses this question. Which of the following features of this presentation are consistent with pseudobulbar affect? Is it 1, a history of stroke, 2, residual neuromuscular deficits, 3, short and abrupt episodes of crying and laughing, 4, all of the above, or 5, 1 and 3?
Open up your mind and see like me. Open up your mind.
All right, good job, guys. About 65% of you guys this. Yeah, we made mention. You have an underlying neurological insult, and then subsequently you've got a situation that, again, includes short and abrupt episodes of crying and or laughing. Now, in the past, there have been different types of terms utilized to describe pseudobulbar affect. The video, the snippet that we saw, talked about emotional incontinence. That's, I think, a nice example. When you take a look at the aspect of somebody not necessarily being able to have good bladder control, well, this, in essence, would be the aspect of not having that emotional control also. Pathological laughing and crying, because typically, if the situation is incongruent to the circumstance, it's going to seem weird, right? Odd, out of place. Affective lability, again, the aspect that your emotional tone is running rampant. There's very little regulation associated with it, forced crying even. And by the way, we'll take a look at a video vignette because, it's nice to see examples. And keep in mind, the previous video talked about the aspect of different degrees of affectation, but we'll see one that's pretty extreme, emotional discontrol, emotionalism, and so on. In fact, before the term pseudobulbar affect actually came to pass, based on the aspect of the only medicine that's currently FDA approved, there was talk about intermittent explosive, emotional disorder, all sorts of different things, but they all tie into this particular theme. So, how would this appear, right? Well, typically, when you see these episodes, they're disproportionate to the situation and or mood. And sometimes the episodes can occur spontaneously and voluntarily with little or no visible reason. Now, they're incongruent because they're inconsistent with what the person's mood is like. Ask them, how do you feel? I feel fine, but they're crying. That's odd, right? And typically, these episodes are short and abrupt, which is very different than, say, somebody with depression, where this is a problem that's been brewing for weeks, if not months. And in essence, keep in mind that dependent on the aspect of the underlying neurological problem that the individual may have actually had, crying may appear as weeping with or without tears, sobbing or wailing, crying with inarticulate sounds, or having facial grimacing in association with this emotional outburst. So obviously this is going to differ from the aspect of the outpatient setting versus a long-term care setting, and that's helpful for us to keep in mind. Let's take a look at this video here.
Let's just start reading. How long has this been?
About 2 minutes in the kitchen, and he just came in. He stopped. He was talking about Allie.
No!
Greg, do you want some of this?
I can't help this.
It's okay.
I don't want to.
It's all right.
Something is making me do this.
I know, honey.
I don't know what it is.
You're right. It is.
It's like creeping up on me.
Yep. And we're going to try and figure it all out. Get it to stop.
By the way, you watch that video. How does that make you feel? A bit uncomfortable, right? So generally, the reason that I make mention of this is that, episodes can look like this, and generally when we see someone wailing, crying, again, and they don't really have solid control over it, it seems odd. But keep in mind also that there can be sort of a flip side situation. We see something like this, it makes us feel a sense of dissonance, right? Let's take a look at the opposite side.
Hey.
Scott.
Yes, I'm good.
No, you're not.
Thank you. So you see the second vignette, right? And doesn't feel as distressful for you, right? When you see someone crying, that feels uncomfortable. You see somebody laughing, that doesn't feel that uncomfortable. In fact, it makes you smile and you're like, oh, I want in on that joke, right? But when in reality, you've got a situation that's somewhat tragic. I mean, you've had somebody that may be describing someone being killed in an accident or something else along those lines. Somebody starts cackling like that. You're like, whoa, are you okay? So that's the interesting thing, is that individuals then oftentimes are ostracized, feel embarrassed over the aspect of what they're experiencing and manifesting, and so it becomes a problematic issue. Let's take a look at this other question. PBA is most often mischaracterized as what? Post-traumatic stress disorder, depression, bipolar disorder, or part of an underlying neurological condition. Let's take 10 seconds.
Come on and stir it up. Ooh, little darling, stir it up. Whoa. It's been
All right, interesting. So you guys think depression, bipolar disorder? You know, oftentimes people think that pseudobulbar affect is actually what a quarter of you would have ascribed, part of the underlying neurological condition. And let's take a look at why that's so. So, well, I take that back, depression, but also the aspect of the underlying condition that the individual has. So depression based on the aspect that, you know, people are crying. So the natural slant is, oh, that person's depressed. You know, just like the case that I shared with you a little earlier, this gentleman came in, he basically said, I don't know why my doctor asked me to come see you. And then all of a sudden he started crying. And I said, whoa, you know, you've obviously had a stroke. How do you feel about that? And he said, well, you know, not good, obviously. I said, well, have you really felt down about this? And he said, well, no. And I said, well, why are you crying? And he said, well, I don't know. And then I said, well, I know why you're here. And he was like, you do? And I said, yeah, I do. Because in essence, you know, when you take a look at conditions such as stroke or dementia, individuals, as they become cognizant of the neurological insult that they've experienced, may end up feeling depressed. And you may also see different types of behavioral manifestations in individuals that you think are part of the underlying issue. But in reality, you may have overlapping things. And as a consequence of that, we're not necessarily addressing the entire constellation of issues. And if we aren't ferreting out the aspect of additional features, we're going to miss the boat and not necessarily get that individual fully well. So the interesting thing is that if we know that 1 out of 2 individuals, for example, with traumatic brain injury may be suffering from pseudobulbar affect subsequently, how many of you actually just asked someone, hey, have you ever had your bell rung? Huh? What's that mean? Well, you know, struck your head. And the amazing thing is that many people will say, well, sure, yeah, I sure have. And if you follow up with a second question of, do you ever tend to laugh or cry for no reason or exaggerate it based on the circumstance that's going on? It's amazing how many people will actually say yes, and they've never been asked those 2 questions. So the interesting thing here is that, you know, when you take a look at intersecting, you know, pie charts, you know, these Venn diagrams here, we're looking at the aspect of the overlap between depression and pseudobulbar affect. But the important thing here is that, again, with depression, you obviously have a situation that's been brewing for weeks, if not months, if not years. Whereas with pseudobulbar affect, you don't have a sustained situation of feeling down. But the important thing, though, is that the common feature is that tears will course out of the eyes and make other people feel a bit uncomfortable. You know, we see tears, and we oftentimes want to try to help and assist. But the interesting thing is that when you take a look at the aspect of individuals having, again, the misperceived situation, oh, it's depression, just based on the aspect that there's tears, is not necessarily a good one. And again, keep in mind also with dementia or with depression, you've got different ways in which these particular problems will set in. with, say, dementia, you've got an insidious onset with a gradual progressive decline. With depression, dependent on the aspect of whether you've had a previous episode or not, there might be a likelihood of you developing something over the course of weeks, months, possibly years. And the duration with both is obviously going to be longer. The progression with dementia, bless you, is irreversible, whereas with depression we can basically control symptoms well. The individual with depression is generally alert as opposed to with dementia. Once the problem's actually waxing, waning into a greater degree of severity, the individual is going to be having additional problems. But then you also take a look at other features that are nicely circumscribed here, and what you'll note is that these are different issues than what the individual with pseudobulbar affect will have. But keep in mind that when you take a look at why we feel that, geez, I just don't see any patients with pseudobulbar affect, it's because oftentimes people aren't going to come in and actually say, I'm having these uncontrollable bursts of laughing and or crying. And oftentimes the healthcare professional is going to be unaware of it. And by the way, I can tell you, I've only had a handful of individuals actually presenting symptoms before me in the clinical setting. It's oftentimes when individuals are on their own. And the thing that was actually quite enlightening for me, several years back, when I first really started looking for this particular problem, was when I had family members in conjunction with the individual suffering with this illness, and upon filling out something like the CNS-LS scale, the son or daughter would look over at mom or dad and say, what are you talking about? I've never seen you have one of those episodes. And the parent would say, well, I'm having those. Doesn't mean that, if you've not seen them, doesn't mean that it's not happening. And for me, that was actually an eye-opening moment, because I've always expected to see in front of me what's going on with that individual. But oftentimes these episodes may not be present when the individual is before us. So keep in mind also that PBA may oftentimes be mistaken as an associated feature tied in with a primary neurological condition. And I described the aspect of the individual with dementia or with stroke or with traumatic brain injury, because oftentimes different types of neuropsychiatric manifestations after a head injury can be quite daunting. So we talk about the aspect of why we think many individuals go about flying under the radar. So I'll give you some examples that are additional. With dementia, again, maybe early on, it's predominantly a cognitive flaw, and then subsequently day-to-day activities suffer, but then behavioral changes set in. And oftentimes those behavioral issues might be tied in, or again, that individual might end up getting depressed as well. But keep in mind that pseudobulbar affect may coexist in individuals with, again, an aggravation of their underlying neurological condition. Same thing with stroke. So most individuals will develop a memory problem, but most will also develop a mood problem with depression. But keep in mind, these are also individuals that have a likelihood of developing pseudobulbar affect, and certainly with traumatic brain injury, same thing ties in. So the important thing here is, again, just keeping our peepers open and asking appropriate questions, even in individuals in whom, again, we think, well, this is just all part of the constellation of symptoms that they've had. So I'll give you some additional examples. With Alzheimer's disease, we obviously know, the Alzheimer's Association Facts and Figures basically says right now every 68 seconds somebody develops this illness. By the year 2050, it's going to be every 33 seconds. It's a serious problem, right? Biggest likelihood of developing, getting older. And when we tie in the aspect of a healthy control, whoops, can we go back one, please? And you take a look here, obviously there's going to be a difference along the lines of the lateral ventricles and certainly the laying of waste, generally in the temporoparietal region and subsequently moving over to the frontal cortices. But the key criteria is that the National Institute for Aging and Alzheimer's Association, as well as the DSM-5 are great guidelines along the lines of diagnosing somebody with Alzheimer's. With vascular dementia, clearly, there's typically a scenario where somebody ends up with a stroke, and then subsequently by doing a routine scan like this, we're able to pick up whether somebody's had a lacunar infarct, encephalomalacia, But we generally can associate the aspect of a neurological finding tied in with the neuroimaging correlating. And obviously, that's why it's important to address conditions like high blood pressure and endocrinopathies like diabetes. But these particular issues may also evoke additional problems, such as pseudobulbar affect. So, do we currently screen? And if so, how? Well, the interesting thing is that pseudobulbar affect is a clinical diagnosis. And generally, the important piece here is the history. Has there been some sort of neurological insult? And what's a symptom pattern like? Are there episodes of inappropriate laughing and or crying? And obviously, our differential should be in there, ruling out depression, anxiety, a dementing issue, and maybe associated features, but there's no specific labs for this. So it's interesting. Jeff Cummings, dear friend, very well-known neurologist in the field, he proposed some specific criteria previously. And again, the whole aspect of this diagnosis comes from the aspect of, again, looking at emotional responses and asking the individual if there's any inconsistency with what the person is feeling internally and what they're manifesting outwardly. Generally, it's not going to be dependent on stimulus or excessive issues. So again, it can come unwanted and just boom, sudden and episodic. Generally, it's going to cause distress, embarrassment, impairment, and it's not accounted for other conditions. It's not drug-related. And then subsequently, let's take a look at another case that'll help illustrate this a bit further. So we've got a 34-year-old Caucasian female who presents with episodes of mood instability. She was diagnosed with bipolar disorder previously and treated with a mood stabilizer appropriately. Treatment for bipolar disorder significantly improved her mood overall, but she still reported periods of emotional instability. She was reporting episodes of crying even in the absence of other symptoms of depression, and her crying episodes were impacting her function at work. She asked a very good question: would an antidepressant help me out? What do you guys think? Which of the following might be appropriate at this time? 1, adding an antidepressant to her mood stabilizer. 2, administering the mood disorder questionnaire. 3, referring to a psychiatrist for further evaluation for her bipolar disorder. Or 4, asking about a history of a neurological condition, for example, traumatic brain injury. What do you guys think? Let's take 10 seconds.
Since you're heading up to Carolina, you know I'm gonna be right there behind you.
All right, good job, guys. Man, I'm in with a sharp crew here. So, this is pretty good. It's really interesting. I'll share with you another eye-opening moment for me in regards to, again, this underlying pathology. I had the ill-conceived notion that sometimes things just are going to exist in a vacuum. And for me, it was eye-opening also when I had an instance just like this particular young lady who basically said, yeah, I know I need to get treated appropriately, but, I'm still having issues. Let's take a look at this particular history with this young woman. When asked about her neurological history, she basically referred that she was a collegiate athlete. She played soccer and basketball and continued to play competitively through her 20s. And several times she definitely had, again, injuries consistent with traumatic brain injury. I don't know if you guys have seen, but man, sometimes those soccer balls come at 60 miles an hour and somebody heading those balls, there's going to be shear and counter shear forces at play. And subsequently with this young lady also, she hit the deck a couple of times playing basketball, and she actually played for the school where I trained at, the University of California in Irvine. So, again, I was particularly interested in this particular young lady. Which of the following might be appropriate at this time? 1, requesting a CT of the head and neck. 2, administering the CNS lability scale. 3, referring to a psychiatrist for a workup of potential pseudobulbar affect. Or 4, initiating treatment with an SSRI or dextromethorphan/quinidine. Let's take 10 seconds, guys.
Paranoia strikes deep.
All right. So good job, guys. 44% of you said, you know what, I'd like to see what this CNS-LS scale shows me. You know, obviously, head injury would have occurred previously, so right now getting a head and neck CT probably wouldn't really help out much. And then subsequently, again, you could probably deal with this yourself rather than referring this out. So let's take a look at some additional features here. This is what the CNS-LS scale looks like. So you've got 7 questions. The individual basically scores them themselves. And if you'll note, each one of the questions either asks about crying and or laughing. And the individual's responding, hey, it never happens, or it's happening all the time, right? And so the interesting thing is that a score of 13 or greater would be suggestive of pseudobulbar affect. And so the important thing with a case just like the one that we saw previously is that, if you've got a condition that's a roller coaster ride where people sometimes have depression, sometimes they've got this hypomania or mania, keep in mind that half of the time, somebody that experiences bipolar disorder, they will be euthymic, meaning there's not going to be any mood oscillation. The problem is that when mood oscillation occurs, a good 70% of the time, people actually are in a depressed phase. Lou Judd, when he was the chair of the department here at UC San Diego, did a lot of work in this particular area, and he actually helped, boom, cast a lot of light into this particular condition, which is actually very good. Because it then sensitizes us to the aspect of what to expect or look for. But the interesting thing for me with this particular case that we just went over is that, I would have never really asked somebody with an underlying affective problem additional questions. In her case, though, again, when we further teased out the situation, even in periods of feeling euthymic, where there was no mood oscillation, she was still having these episodes of crying for no reason. And I said, well, you know what, let's check this out. It turned out, she definitely had head injury, and it definitely turned out that she had pseudobulbar affect. So she actually had 2 things brewing at the same time, and I would have, because of the aspect of dealing with the underlying affective problem, not necessarily have suspected that there was a secondary issue. Upon treating her appropriately, guess what? All of a sudden, she looked the best she had ever looked. And that also was an eye-opening moment for me. So how do we treat this? Well, first and foremost, our goal is to reduce the severity and the frequency of the episodes, right? So what targets have we had? Well, it turns out that serotonin or epinephrine, or the usual monoamines that we talk about, glutamate being the main excitatory neurotransmitter in our brain, seems to be important. And in the past, different drug classes were used for pseudobulbar affect. Among them, serotonin-specific reuptake inhibitors, tricyclic antidepressants, antipsychotics. And it turned out that, when you look at NMDA receptor antagonists, dextromethorphan, which is an antitussive, is a good model to look at also. What you'll note is that historically there were very few studies really investigating the aspect of pseudobulbar affect. At the present time, there's only one FDA-approved treatment, and that is actually a combination of dextromethorphan, that antitussive, with a touch of quinidine, which is obviously an antiarrhythmic, but the doses that are utilized are small, so as to then be able to actually lengthen the half-life of dextromethorphan from 2 up to 13 hours. So let's take a look at the studies that had been done with SSRIs to try to treat pseudobulbar affect. What you'll note first and foremost is that the ends were pretty small, right? 13, 6, 10, 26. So again, not really great data out there, and predominantly using medicines like Prozac or Luvox, Paxil, Celexa. And what you'll notice is that, there were some reductions, but really not a consistent overall feature tied in with this. And when you take a look at, again, different types of medicines, including, tricyclic antidepressants or SSRIs also, you see outcomes that would be suggestive of different things. And then subsequently, when you now take a look at combining dextromethorphan and quinidine, now you've got much larger patient populations. And what you'll notice is that there's a nice reduction in severity. And this was obviously part of the whole rationale along the lines of saying, hey, you know what, let's take a look at this. Local company, here in Southern California basically actually took the lead on this, and as a consequence of that, got the FDA approval on the first and only medicine that's indicated for pseudobulbar affect. And the importance here is that when you take a look at the active ingredient of this particular medicine, it's quinidine, that antitussive. But it doesn't mean that if you chug a bunch of cough syrup, you're going to be able to get to where you need to get. Keep in mind, dextromethorphan's got a very short half-life. So you can't really be able to get the appropriate concentration that you need. So one way in which this was actually accomplished was to tie up the particular oxidative isoenzyme pathway that metabolizes the medicine. And quinidine does that through the 2D6 pathway. And basically, by doing that, you see a big kick in regards to the overall concentration. Whoops, can you go back for 1 second? I keep hitting the wrong button. So when you take a look at the overall concentration of just dextromethorphan versus that combination, obviously a big, big difference. And as a consequence of that, also changing the half-life from 2 to 13 hours and enhancing the overall bioavailability associated with dextromethorphan. The whole way that we conceptualize this particular medicine working is through the glutamatergic pathway. So this medicine is an NMDA receptor antagonist, but it's also a sigma-1 agonist, which means that it has effects pre- and postsynaptically, and basically, actually ties in nicely with how it is that this medicine would work. The pivotal study that garnered the approval for the medicine is noted here, and specifically, when you take a look at the patient populations, it was predominantly patients with amyotrophic lateral sclerosis and multiple sclerosis. And it's interesting because if you take a look at some of the side effects associated with the medicine, first and foremost, this is not going to be a sedating medicine, but if you take a look at the aspect of coughing that was noted as one of the byproducts associated with the study, you would think, wait, it's an antitussive, right? What's the story with that? But keep in mind that patients with ALS have weak diaphragms, and as a consequence of that will cough also. So I always find that sort of interesting that, when you take a look at side effect profiles associated with different studies, it's really interesting to look at. But the interesting thing based on this 3-month study was that as you take a look, every single point of measurement which individuals were tracked basically showed that active treatment really contrasted widely with the individuals that were placebo-treated, meaning then that when you take a look at the overall reduction in episodes that people had with pseudobulbar affect after successfully being treated with this particular medicine, this combination of dextromethorphan with quinidine, it actually showed success. And in fact, at the conclusion of the trial, half of the patients that were actively treated were having no episodes, as opposed to a third of individuals that had been on placebo. That was convincing data to the FDA. Obviously, every medicine has the possibility of side effects. And if you take a look, these are the side effects that were reported in that pivotal study. So you see diarrhea, dizziness being the only things that are over 10%, so meaning 1 out of 10 individuals would have actually experienced that. Contrast that with placebo. Point number 3 is the one that I was mentioning. You're like, what? Cough? But again, helpful data along the lines of really taking a look at the aspect of something that not only was efficacious, but well tolerated and well accepted. So the great point behind this is that, opportunities such as this right now afford us a way of enhancing our overall database. And what you'll hopefully take back with you is that pseudobulbar affect is not uncommon in patients with neurological conditions. And if you include MS, ALS, stroke, dementia, TBI, it's important to keep our peepers open for that. It's characterized by episodes of laughing or crying that are inconsistent or greatly exaggerated with the patient's mood. The episodes are generally paroxysmal and oftentimes misdiagnosed or mischaracterized. So it's important because this has a degree of impact on the individual's function. And if we can offset that, that's helpful. And it's as easy as just asking patients about history of neurological conditions and whether they've had crying and or laughing episodes that are incongruent or exaggerated. And also, again, we have ways of utilizing tools, and we also have data regarding what's been utilized and what's current in helping us out. With that said, let's take a look at our previous questions, and I want to, please, guys, Make me shine here, will you? All right. So the first question. In the PRISM registry study, remember that study? The prevalence of pseudobulbar affect was highest in patients with which of the following conditions? Was it 1, stroke, 2, dementia, 3, multiple sclerosis, or 4, traumatic brain injury? 10 seconds.
Heard the mission bell, and I was thinking to myself, this could be heaven or this could be hell. Then she lit up a candle.
All right, look at that. Nice movement, right? So 40% of you guys, said traumatic brain injury, good 18% more actually got it at the end. So yes, it was actually traumatic brain injury, 1 out of 2 individuals. Okay, cool. That's some good learning there. In a survey of patients with pseudobulbar affect, approximately how many reported being housebound by their symptoms? Was it 10%, 20%, 30%, or greater than 40%?
Oh, the pompatus of love. People talk about me, baby. Say I'm doing you wrong.
All right, look at that. See? Nice. 45% at the beginning, 80% at the end. I love it. That shows that you guys are paying attention. What about this one? Which of the following agents are FDA approved for the treatment of pseudobulbar affect? 1, fluoxetine. 2, citalopram. 3, dextromethorphan. 4, dextromethorphan with quinidine. 5, all of the above.
I hope you understand the green eyes, yeah, the spark.
Wow, look at you guys. See, at the beginning, less than 1 out of 5, and now at the end, 9 out of 10 of you guys are getting this right. Love it. Okay, what about the case? 63-year-old woman, history of hypertension, dyslipidemia, ischemic stroke, excessive crying. She says, she started crying after a stroke 6 months ago, staying at home. All the following might be appropriate at this time except 1. Administering CNS lability scale. 2, asking the patient if laughing or crying episodes match her mood. 3, initiating empiric therapy with SSRI to identify and treat potential pseudobulbar affect. Or 4, if further workup suggests pseudobulbar affect, consider prescribing dextromethorphan/quinidine.
And it always goes on and on and on and on and on, on and on and on and on and on it goes.
Oh, come on, guys. Really? Oh, no. You'd be starting empiric therapy with an SSRI? Come on.
All is true except.
Oh, with it. Good job. Good work. How often will you consider a diagnosis of pseudobulbar affect after attending this conference in patients who report repeated episodes of laughing and or crying? Never, rarely, sometimes, often, always.
Positive, don't mean to tell you how to feel, but I'm a firm believer in the power of the plastic. Positive plastic.
Awesome. Good job, guys. From 4 to 51? Cool. Rate your confidence in your ability to recognize pseudobulbar affect in your patient population. Not at all, slightly, moderately, pretty much, or very confident. You guys look like a confident group. All right, okay. Not at all initially, and then 0. Look at that, and then all of a sudden, pretty much and very. I love it. That's good stuff.
All right, we got 2 microphones in the room. Any questions? Here we go, right up.
So I have a twofold question. I have a woman in a skilled nursing facility had a stroke with right side hemiplegia in August.
Yep.
And how long does it take, for this to take effect? I started Nudexa about a month afterwards, and it seemed to help her, but she complained about a cough. And of course, I'm thinking, oh, come on. But the right side, maybe hemidiaphragm was paralyzed.
Yeah. Yeah.
And the other second part of this, did you see the thing on Doximity about a week ago about how they blasted this product?
Yes.
So can you comment on
Yes. So first part, Just like also with, say, traumatic brain injury, what's a temporal time frame in which subsequently there's the appearance of symptoms? And that unfortunately is still sort of a big area where you sometimes see an apparition of symptoms relatively quick after the neurological insult, but sometimes there's a bit of a lag also. So the important thing is that that is actually an area in which we need to get more information in regard to what usually occurs. Give you an example. So with vascular dementia, typically you'll expect to see, again, a couple of months after the vascular insult, some sort of cognitive decline and a stepwise deterioration. Same thing with, say, Parkinson's disease dementia, or Parkinson's disease psychosis, where you've got specific time frames, again, of having had the condition for at least a year, if not, and then subsequently seeing specific symptoms set in. So that's an area that needs to be filled in a bit more. The second part, I did see that, and you know what? It's unfortunate because from the read, it was a very slanted view that was being taken by the so-called journalists, and so sincerely speaking, I think that it's unfortunate. Yeah. And I think that, keep in mind, obviously, we're not just utilizing this particular medicine in a scattered fashion where it's not indicated. But in somebody with pseudobulbar affect, this is a medicine that can turn the tide completely. And help with the reduction of other medicines that may potentially evoke even more harm to the individual if exposed over longer time periods.
And it helps the patient, the staff loves you.
Yeah, absolutely. Yes.
My turn?
Doesn't work. Okay. So I have two questions. One was, you didn't address the length of time that the medication would be administered because...
Yeah. So if you guys recall that one slide where the overall remission was 51% versus 29%, the package insert of the medicine recommends that you check intermittently to see whether there's been a spontaneous remission in the individual. For the most part, my personal experience has been that at times when we've tried that out in individuals, the symptoms come back and oftentimes require reintroduction back of the medicine. But the package insert would suggest that you check to see if there's been a spontaneous remission in someone.
And then the other question is can you use this in conjunction with an antidepressant? And if you're going to use something which is typically used in post-CVA patients, which used to be a lot of times a tricyclic, which is also a class 1 antiarrhythmic along with the quinidine, is there a synergistic potential?
Great points. So yes, you can use in conjunction, but keep in mind, most package inserts of medicines that have some potential impact on the QT interval will suggest keep your peepers open, particularly when you're combining medicines that have this type of an effect. And you're right, there is a proportion of quinidine in these capsules. So we're talking about 20 milligrams of dextromethorphan with 10 milligrams of quinidine. But keep in mind also that that's a super minuscule amount of the antiarrhythmic. So when you take a look at the lowest strength that you can usually get for quinidine is what, 200? And typically, to treat somebody, again, with an antiarrhythmic such as quinidine, you need much higher amounts of the medicine. So the doses that have been studied systematically, basically suggest that this is actually a pretty good treatment, but keep your peepers open, right? And obviously also, the other interesting thing is that the medicine does have a bit of an SNRI type of an effect. So, you would want to be careful with also monoamine oxidase inhibitors because of the possibility of serotonin syndrome, at least, that's also addressed on the label to have an awareness for. And then, yes?
How can you tell if the patient is faking it?
How can you tell if the patient's faking it? Well, for the most part, people don't want to, take additional medicines. So, you may have some sort of a Munchausen syndrome, thrown in there intermittently, but for the most part, people just don't want to have something else. You know what I mean? So for the most part, people aren't necessarily going to be faking it. It is important, though. Like I said, I've had a handful of patients in which I'm actually visualizing the episodes in front of me. But for the most part, they're happening outside of my office. And so to your question is, well, you know, would somebody be faking this? You know, oh, for this? No. I mean, you know, the patients that I've treated with this condition usually aren't the ones that are asking for some type of a disability. But you can definitely tell, like, for example, the gentleman that had the stroke, you know, there's going to be a residual hemiparesis, and that's going to be more of a disability per se than the aspect of the emotional outbursts that subsequently get noted.
I have a question. A couple things from our audience at home. Someone makes an interesting comment that laughing is supposed to be a good thing for health. Does laughing associated with PBA contribute to good health?
Yeah, I don't think that's been studied per se, but like I said, when we showed the clinical cases, you know, you see the individual laughing, and it kind of makes you smile also a little bit, right? And you're like, I want in on that joke. And then you see the other guy that's crying, and it kind of makes you feel badly, right? So it's really interesting. For the most part, what I've encountered clinically is more the crying side than the laughing side, but it can be interspersed in between.
Right, and the second part, and I'll let you ask another question. A lot of questions here. The thing that we deal with all the time, cost and coverage. Any comments on that and how we get it? Because some people are having a hard time.
So my understanding is that this is the only medicine that's currently FDA approved, which means then that, you know, there's nothing else. There's no other alternative per se. So generally there's going to be decent coverage for the medicine, and generally people can actually request information through Avenir, which is the company that actually makes the medicine. But yeah, it's important, particularly when you've got a one and only type of an agent. Not yet.
I'll speak up.
There you go.
Now it's working.
How about now?
Yeah.
Good. I've seen anecdotally something very similar with electrical injuries, like getting struck by lightning in the head. And I'm wondering if there's a known association and perhaps a side effect with electroshock therapy?
Yeah, you know what? That's an interesting thing. We generally don't think... ECT per se, and you're all well aware, electroconvulsive therapy is something that is approved for treatment-resistant depression. We don't really know how it works, sincerely speaking. You know, we've had this around since the late 40s. A couple of Italians basically, you know, found this guy in the railroad tracks, and basically, you know, the guy was pretty kind of, you know, tipsy and so on. And they said, "Hey, come here, let's see how this works out on you." Genuine story, Chiletti Abini. And then subsequently, boom, you know, flashed a bit of electricity through the guy, and the guy's mood improved. And then subsequently, we kind of figured it out. Oh, this is good. The problem early on was that we didn't have succinylcholine back then, so people were having broken bones because when you know, hit somebody with electricity in the head, guess what? It's like, you know, you're going to get like a, you know, tonus, and then, you know, seizure-like activity, basically. And that's still what we look for with the aspect of cuffing an arm. But it is now a very safe treatment modality. And you've got people like Mrs. Dukakis that have gone nationally and talked about the virtues associated with ECT. Problem with ECT, though, is that it wipes your short-term memory for about 6 months, objectively, and subjectively possibly even longer. So is it as benign as we think it is? Well, you know, if it's having that type of a deleterious effect, who knows? So that's an interesting question. You know, if somebody gets hit by lightning, well, I think that's a very different situation than the aspect of having ECT. We don't think that ECT is going to, you know, cause permanent damage per se, but it's not really been well studied. We know short term, 6 months out at least, objectively, you definitely do see short-term memory deficits. So that's something that's not really been well studied per se.
I have one last question, then we're going to move on. Someone's wondering about pediatric population, if this condition exists, and if you do find it there, would the treatments be the same?
It's interesting. The medicine that's currently FDA approved has not been studied in kids. So we really don't have any data with that. Theoretically, you could possibly see that, absolutely. And, again, it's as easy to note in head injury. And I've certainly seen the aspect of emotional lability, again, the aspect of very, very easy tearfulness in individuals that have had traumatic brain injury that are young. But again, there's nothing that's been systematically studied in a pediatric population.
Cool. I think we're going to have to call it there. If anybody has additional questions for Dr. Alva, maybe they'll stay afterwards. And he lives just up the road, so you can probably send your patients there if you need them. Thank you very much,
Thank you
Dr.
so much,
Alva.
everyone.
Okay, I know there were some more questions at home. I'm sorry I couldn't get to them all. So we're going to switch gears. I'm delighted to bring Ms. Nancy Berman. She is an adult nurse practitioner, certified menopause practitioner, and Millennium Affiliated Physicians in Farmington Hills, Michigan. She's a true national thought leader in women's health and is passionate about teaching her colleagues. She publishes regularly, lectures nationally and internationally. I bring you a star-studded faculty today. So her areas of interest are cervical cancer screening, which she'll discuss in the first hour, and osteoporosis in the second hour. So please welcome Ms. Nancy Berman.